Thanks very much, Jo. So I've been asked to talk today about just a little bit of an overview of the service. And this is actually a talk that myself and Marie Ray, who's our senior cardiac liaison nurse, are on the programme for doing. But actually a lot of this work was done by Jo. So I'd just like to acknowledge Jo for her part in this presentation as well. And it's a talk that we did previously to the cardiac champions, which I'll talk about a little bit later. Just to see if this will arrow down, which doesn't seem to be doing at the moment. Okay, Jo. Hang on, we've just stopped. We might just stop and reshare the screen or something, because it was working like 3 minutes ago. Should we come out and come back into it? Go back to concurrence and see if it was it. Sorry, just bear with us and we'll try and make this work. Yeah. So what I'm going to just cover in here is a little bit about the fetal service here in Leeds. I'm going to talk about the referral criteria, and I couldn't resist but to show you some pictures as well, because I can't really do a talk without showing you some fetal echo pictures. So we'll do a little bit of that at the end. So this is the fetal team here in Leeds. So it consists of a multidisciplinary team really. So we've got the fetal cardiologists, Dr. Shuba Barwick and Elspeth Brown, who is just retired last week, but is going to be returning to the service in a few weeks. We've got the team of cardiac physiologists or sonographers. So we're specialist cardiac physiologists rather than being obstetric sonographers. And we've also got our clinical nurse specialist team, so currently being led by Marie Ray, who's in the middle here. Okay, but we've also got Lindsay and Emma involved in the service as well. Behind the scenes, we've also got our clerks who make all of our appointments and are absolutely invaluable to making the service run smoothly. They frequently have to call the patients who often, as you can imagine, can be quite upset and distressed that they're having to come to see us. They prepare all of our paperwork as well. And then we've got our secretarial support. So our secretarial team types all our letters, sends the reports back to the screening coordinators and obstetricians. And obviously that needs to be done in quite a timely way if we've got abnormal reports. So why do fetal echo? So the main reason is we want to identify those babies with congenital heart disease in the antenatal period so that we can provide the parents with information. This will allow them to make decisions if they need to make decisions, but also so that we can ensure that babies with duct-dependent lesions are born in the tertiary centre here in Leeds with access to immediate care if that's required. So obviously the sort of the prime example there is transposition of the great arteries, where it's really, really important that we deliver the babies here in Leeds. It also gives the parents time to prepare for the future and to make plans as well. So if they've got, other children, often they're going to have a baby who's born with a complex heart problem. They've got some time to prepare the whole family and put things in place and put their support networks in place. If babies are born in good condition in the right place, then obviously it means that we're not having to transfer sicker babies by emergency transfer. So that's obviously key to keeping babies in a good condition. And it also means that we're keeping mum and baby in the same unit as well, which you can imagine it's quite difficult if you're sort of in Chesterfield and your baby's rushed to Leeds and you can't go with them if you've had a C-section. So it's really important we try and keep mum and baby together. So we know that about 1,000 newborn babies leave hospital from the UK every year with an undetected major heart condition. And this is what we're trying to prevent, and we're trying to reduce the number of babies that we don't know about. So this is some information, I'm sure probably Shuba's going to touch on this in her presentation as well. But you can see that year on year, the antenatal detection rates have improved. So things that are very abnormal, things like hypoplastic left heart syndrome, back in 2012-13, the antenatal detection rate was about 85%. Now it's up to 93%. But the other things that are really important as well, you can see transposition of the great arteries. We used to be really very bad at detecting, and now we're much better. And that's because of the introduction of these additional views that are now part of the routine screening programme. So who do we work with in the network? So we work with a whole variety of people. So the screening coordinators are really a really useful link for us, and we've had some study days with them in the past. Community midwives, fetal medicine. It's really important for us to have strong links with the fetal medicine team. And over the last couple of years, we've actually relocated our fetal cardiology service to be sort of adjacent to fetal medicine, and that has made a massive difference. And so now we all know each other much better, but we accept referrals. If fetal medicine see a lady that then turns out to have a heart problem, often we can see them at the same time, and so it's working really well with us being so closely linked. Obviously, we receive referrals from obstetricians from around the network. We've also built up a really strong bond with the hospices, and that's really the liaison nurses that have managed that link. And so if patients have an antenatal diagnosis and the parents opt for comfort care, then we can put all of that in place prior to babies being born. The paediatricians with an expertise in cardiology are another of our links within the network, and also external organisations, so Tiny Tickers and ARC, Antenatal Results Choices, I think that stands for. So those are other agencies that we might refer our patients to for more information. A big part of the role for me is that we support the obstetric sonographers within the region. And so what we've identified over the last couple of years is some cardiac champions within each hospital. And what the aim of this is to try and give these people some additional training, so that within each unit there's somebody with a bit more cardiac expertise that can be a second pair of eyes to look at a scan before a referral is made. We've made some training resources to support this, and we'll show you some of those in a minute. And we've been doing some online training sessions during the COVID period. And again, that was Joe that kind of kicked us up the backside to get us organised, because we were going to do a session sort of face to face. But actually, when COVID hit, we actually discovered that we could still do virtual sessions. And so we've been doing this sort of every 6 to 8 weeks, and that's been working really well for the past sort of 18 months. And so various members of the team have been supporting that. We've also working with Tiny Tickers to support sort of hands-on face-to-face training as well. And again, that kind of stopped during COVID, but we've just restarted. So so far we've already been to St James's and to LGI, to Airedale, and we're booked to go to Scunthorpe. But that's a link that my colleague Sam Bainbridge and myself go out and support Tiny Tickers and do the training in these other hospitals as well, in Yorkshire, but also throughout the country. One of the things we're working on as well is to give people better feedback. And this is what the one area that we know that we really do need to improve. So we're looking at the mechanism of letting people know whether or not there's any antenatal or any postnatal diagnoses that weren't picked up antenatally, but equally when referrals are made, to actually give people feedback as to whether or not there was an abnormality and what the outcome was. The picture on the right-hand side there is just a picture of the training resource card. So we've produced these cards during the COVID period, and this is based on a card that we had previously, and we've basically updated that and put some really nice images and some nice schematics. So that's acting as a really nice training tool for us to use. I'll just get this to go to the next slide. So that's a picture of our scan room. So you can see it's quite a nice environment to scan in. We've got a dedicated system that we use for our fetal work. And we're now really close to the fetal medicine department, which is working really well. So in this area, we've got our one fetal echo scan room with our one echo system. We've got a dedicated counselling room and a small waiting area. And generally, we see about 1,700 or we do about 1,700 scans per year. So some of those will be repeat scans. So if we see an abnormality at 20 weeks, we'll see them again at 28 weeks and sometimes 32 to 34 weeks, depending on what the diagnosis is. And out of all the scans we do, probably about 450 of those year on year are sent as being query abnormal scans from the abnormal, sort of the anomaly scan. So this is the pathway that occurs in the department. So our referrals now are emailed. At one time they were faxed and phoned through, but now we've got an electronic pathway, which is much, much better. So those referrals are now triaged by the clinical team, in addition to sort of all of the other things that we're trying to do. So, but we always will try and do those a number of times per day. If there are urgent referrals, then we aim to see those ladies within 3 days as per the national guidance, and we try and do that as frequently as we can. But bearing in mind that that actually counts the Saturday and Sunday when we don't provide a service. So if a scan comes in on Friday, we have to try and accommodate them on Monday, if we can, to meet that guideline. So our clinics run daily, Monday to Friday, usually, and we have two sorts of clinics. So we have our high risk or urgent clinics. So these will be a mix of high risk and urgent referrals. And in these clinics, we have our consultant paediatric cardiologist, our specialist sonographer and our nurse specialist present. In addition, we have 2 low-risk clinics a week, and these are sonographer-led clinics. So I have one of these clinics, and Sam Bainbridge has the other clinic. And so these are for referrals such as our lower risk family history clinics. And I think it's really important that people understand that there are 2 different pathways within the service. So occasionally we have patients who might have been booked for our low risk clinic because they've got a family history of congenital heart disease, but then they've had their anomaly scan. There's been a suspicion of an abnormality at the anomaly scan, but because the lady will then say, oh, I'm going to Leeds tomorrow or, you know, next week, an additional referral then isn't made. And it may be that Sam and I are alone. Well, we are alone in that clinic, but there may not be a paediatric cardiologist available to us if we do then find an abnormality. So I would just like to really stress that if you do see somebody during the anomaly scan and you think there's an abnormality, even if they're coming to Leeds already, please will you send an additional referral or let us know so we can make sure the lady's seen in the right clinic. All of our patients are given the results and counselled on the same day following the scan and the report. We always try and get that out on the same day as well. If on the referral form you put who the sonographer was that scanned the patient, then our clerical team will also send a copy of the report to the sonographer, and that's obviously a really good mechanism of getting feedback. So these are some of the things that we've talked about during our Cardiac Champion training sessions that we've been running since June 2020. So these are just a flavour of what we've been looking at. So we've looked at sort of tips that what makes a good referral, what sort of information we want, what to say to the patients when you find an abnormality. We've done a review of normal and the fetal circulation. We've looked at all of the views that are recommended by FASP. And then we've looked in detail at the FASP auditable conditions. So we've spent a session on each of these auditable conditions. So hyperplastic left heart, atrioventricular septal defect, tetralogy of Fallot and transposition of the great arteries. We've looked at a few technical things about how to set our colour up nicely, when to use our Doppler. We know that these aren't mandatory things to do as part of the study, but sometimes it can be really useful additional information. We've talked about measuring heart rate if we've got a baby with an arrhythmia, and when Sam and I are coming out doing the hands-on sessions, then this is something that we're going through with the sonographers on their own equipment so they know how to measure heart rate. More recently, we've been looking at case studies and looking at the outcomes of the patients. So we've been choosing, or we've had suggestions from a couple of different centres of cases that they've seen. They'd like to know what the outcomes were, and we've gone through those and looked at the images that we store and then talked through those. We try and give feedback on referrals. We've produced the training tools which were funded by Children's Heart Surgery Fund, and we've also had some visiting speakers. So we've had the Tiny Tickers John Arnold, CEO, to come in to talk to everybody. And also we've had Sarah Matley from our psychology team to give the sonographers some tips as to things to help their well-being. So who are we going to refer to fetal echo? So anybody with a suspected defect on their ultrasound anomaly scan, patients with a raised nuchal, those with a significant family history, non-cardiac abnormalities that are associated with cardiac abnormalities, and fetal arrhythmias. So we can broadly put those into three main groups. So maternal indications, family history, and the abnormal obstetric scan. So if we look at the maternal reasons first, so this would be if the mum has got congenital heart disease herself, excluding a patent duct or foramen ovale, which clearly are part of the normal fetal circulation. So we would expect those to close. If the mum has maternal complete heart block, any exposure to known teratogens, metabolic diseases if poorly controlled. So we don't routinely see diabetic ladies, but if you know that they were particularly poorly controlled, then we would consider them, and any autoimmune antibodies, so anti-Ro, anti-LAR, and any non-steroidal drugs. So family history is also a sibling with congenital heart disease or heart block, paternal congenital heart disease, inherited disorders, gene disorders, so pop all of those on the referrals, and a history of cardiomyopathy. Abnormal obstetric scan, so if you're unable to obtain the normal heart views, if there's an increased nuchal translucency, either 3.5 millimetres at the first trimester screening or 6 millimetres mid-trimester, if the baby is hydropic, there's pleural or pericardial effusions, extracardiac malformations, so emphysema, those sorts of things, chromosomal genetic abnormalities, and fetal arrhythmias are particularly important. So not ectopics, but if we've got sustained tachycardias over 180 or sustained bradycardias less than 100, we really do need to know about those. And any risk of fetal heart failure, so things like fetal anemia, twin-to-twin transfusion, or tumours. So this is just a summary slide of all of the indications for fetal echo, for which I think you can see there are quite a lot. And this is also summarised in those reference cards that we've given to the sonographers. So have I got a couple more minutes? Yeah, so I think I've got a few more minutes. So I'm just going to just run through, for the people that aren't aware, these are the 5 views that are important, or that FASP recommend that sonographers use to evaluate the fetal heart. And it wasn't that long ago when actually all that we used to do was look at the 4-chamber view. So essentially take this view, and there are lots of things that we could miss if we only look at this one view. And so now we look at the outflow tracts, and we look all the way up to the sort of where the aortic arch and the duct are, which gives us a lot more, much better pickup for things like the transposition. These are some normal views. This is if your fetus is being really nice and well behaved. So we can start off with this situs view. So the spine is here. This is the cross section through the baby's abdomen. We can see the stomach, the descending aorta, and the inferior vena cava. Then if we move up the baby, we then start to see this 4-chamber view. So we can see there are 2 atria, which are equal in size, 2 ventricles, and we can see the valves opening and closing. So we're looking at the heart rate, we're looking at the function of the heart, we're looking to make sure the septum's intact, we're looking to make sure the valves are working properly, and that the baby's heart is the correct size within the chest. Then if we extend up towards the baby's head a little bit more, we start to see the left ventricular outflow tract. If we go up even further, we start to see the right ventricular outflow tract, and then we come up to the 3-vessel view. So this is the newest view that was introduced by FASP. And you wouldn't be able to get this view if your baby had got transposition of the great arteries, but it's also useful in other diagnoses as well. So things like tetralogy of Fallot, cooptation, other things will have an abnormal 3-vessel view. So for me, these are the FASP 5 views, but I very much feel that this is the minimum data set, and that actually we can do a lot more than that. We can use our colour, we can look at things in a bit more detail, but these are the 5 views that are recommended. Just going to show you a couple of examples of very abnormal scans. So this is the baby with hypoplastic left heart syndrome. This is quite an old slide, but you can see here the left side of the heart is very small compared to the right side of the heart, and the septum is very bright and damaged. When we put our colour on, we can see colour in the right side of the heart, but very little in the left. And we've got a regurgitant jet coming back the wrong way because the blood can't go forwards. And that's because we've got this tiny little aorta, which is like a strand. It's sort of about 1 millimetre in size. So this is the baby with hyperplastic left heart syndrome. And this is the sort of thing that we would expect to very readily pick up on the anomaly scan. It looks very, very abnormal. This is an example of an atrioventricular canal defect or septal defect, so an AVSD, and you can see that it's because of the failure of the centre of the heart to form properly and septate. So we've got one big common valve, a ventricular septal defect and an atrial septal defect. So again, in this example, this is very obvious, but as with all congenital heart disease, there's a spectrum of presentation, and these can be really hard to pick up. They can have very small VSDs, they can be big, they can be small, they can be middle-sized. They can be what we call balanced, where the ventricles are the same size, or unbalanced, where they're not the same size, and there could be other abnormalities as well. This is just a couple of pictures from one of my clinics last week. Not my clinic, it was the mixed clinic, thank goodness it wasn't just in my clinic. But this is a patient with a huge rhabdomyoma here. There's also one up here, there's something else here, and this baby was sent from an abnormal 20-week scan. This was the next patient in the clinic, so again, really abnormal heart. You can see the heart is filling the chest from the left-hand side to the right-hand side. This is the left heart, this is the right heart. So we've got a small left, well, a normal-sized left heart, and an abnormal tricuspid valve with an enormous right atrium that is leaking. So this is a baby that we would expect to have a very poor outlook. Just really quickly, the very last slide, so fetal arrhythmia. This is the one that's really important that we know about straight away. So if you see a baby's heart going really, really fast, so over 180 beats per minute, for the sonographers that I know are on the call, then this is one that we need to know straight away, because what we need to do is start some medication to slow that heart rate down, and we do that by giving the medication to the mum. And the quicker we can give mum the medication, the more likely it is that we can revert that back to a normal sinus rhythm. So we definitely want to know if you see anything like that. I don't know whether there's time for any questions or there's any questions in the chat, but that's the end of my